killing me, Smalls. Just want to make sure it starts. There we go. Okay. So really what we want to answer is 4 different questions. First of all, is the oxygen delivery adequate for a patient's needs? Is the cardiac output adequate for oxygen consumption? So they go hand in hand with each other. Is oxygen consumption adequate for the demand? And finally, is the patient's hypoxemia due to a pulmonary problem or due to a low flow state? The definition of shock is really the inability of oxygen supply to match the demand the patient has. I like this definition by Samuel Gross, the rude unhinging of the machinery of life. In essence, that's true. You basically do not have the ability to have the oxygen supply, as indicated by the oxygen delivery, matched with the oxygen demand. If you have demand outstripping supply, you're going to need to go anaerobic, and that's where the body runs into trouble. It's more than just hypotension. Someone could be in shock and have a blood pressure that's maintained as normal. So don't solely go by that. But basically, it's where that cardiovascular response that we should see is inadequate. What this graph is showing us is that as we increase delivery, it should be as we increase oxygen consumption, it should be matched by an increase in delivery. There's some point, though, where the body can no longer provide the amount of oxygen that is necessary, and therefore we end up going into that anaerobic process. There's also a point, though, for which increasing oxygen delivery is not going to get us any benefit. We only need to increase oxygen delivery to match the oxygen needs. Putting putting you on dopamine to improve your cardiac output doesn't make any sense. We've already matched what you need. Does that make sense? Good, thank you. So let's go back in time to 1050 and talk about the cardiac output component of this, since that's the part of the oxygen delivery. We know that the cardiac output is basically the amount of blood that leaves the ventricle and travels through the systemic circulation in a minute's period of time. Normal value is about 4 to 8 liters per minute, and it's derived from the heart rate and the stroke volume. We can create indices of these, so we're looking at it via body size using a Dubois nomogram. And in that case, the normal cardiac index is somewhere between 2.5 and 3.5 liters per minute per meter squared. We know the Dubois nomogram. If I'm 6 foot and 190 in my dreams, I would go ahead and have a BSA of somewhere around 2.1. So dividing the measured cardiac output by the BSA will give me the measured or the derived cardiac index. If you ever want to go, you can get these online. I doubt it. Heart rate, we know, is regulated both from the parasympathetic and sympathetic system. The sympathetic would be a beta-1 adrenergic stimulation. Parasympathetic is through the vagus nerve. There are various drugs that we can use to speed up the heart rate, things like epinephrine, things like other beta-1 agents. And then we can also have a heart rate being affected by blocking the parasympathetic discharge. And this is what basically some drugs like some beta blockers and calcium channel blockers do. Normally the heart rate is maintained and would be increased whenever we have an increase in demand, either due to exercise or from a pathophysiological reasoning secondary to hypoxemia. Stroke volume is basically the amount of blood that is ejected on a beat-by-beat basis, somewhere between 60 and 130 milliliters. And we know that the stroke volume is regulated by the preload, the afterload, the contractility. Those definitions should be familiar to you. And we can also index the stroke volume, calling it a stroke index by dividing by the body surface area. Preload, we know, is an increase in stretch. As you increase the volume into the ventricle prior to ventricular ejection, you increase the amount of stroke volume to a point after which you become non-compliant at that point. Can't measure these directly. We know that we use a CVP. Well, can't measure the volumes directly. We're going to infer volumes by looking at pressures within those chambers. And if you remember back, that right ventricular end diastolic volume is interpreted by looking at the right ventricular end diastolic pressure. At the end of diastole, the pressure within the right atrium, or CVP, is equal to what would be in the ventricle when that tricuspid valve is open. Normal value of somewhere between 2 and 6. And on the left side, we don't have a direct measurement. We're going to use the wedge pressure as a correlate for what the left ventricular end diastolic pressure is, which would then reflect the volume. Just vaguely remember this from prior. Good. Okay. So again, this is what we're kind of looking at as we're going along. And as the left ventricular end diastolic pressure rises, so does the stroke volume. If preload is low, either a low wedge or a low CVP, primarily we have to figure out why we're losing volume and prevent further loss. But we can also increase that volume by use of crystalloids, which is typically in your IV fluids, normal saline, lactated ringers, D5W. Colloids, things like albumin, and in blood. So there are multiple ways to increase the preload. If the preload is too high, we're going to use diuretics. Remember from last fall, the primary types being the carbonic anhydrase inhibitors that are potassium sparing. That are potassium depleting. They're hydrochlorothiazides and the loop diuretics, which are the ones we primarily see in the ICU. Afterload is the resistance of ventricular ejection, what the left ventricle has to pump against, and it's primarily affected by the distensibility of the downstream vessels, which is basically the arteriolar vasoconstriction or vasodilation. It's also affected by the quantity of blood you have, and especially the hematocrit. On the left side, the afterload is indexed by the systemic vascular resistance, and on the right side by the pulmonary vascular resistance. And again, just as the cardiac output could be indexed, we can index this value also. Remember that resistance is a derivation of the Ohm's law, which we know from area resistance is change in pressure over flow rate. Same is true with the systemic vascular resistance being affected by the pressure difference between the aortic, which is the high point, the CVP being the low point, and the cardiac output being the flow. So if we look at high pressure minus low pressure divided by flow, multiply it times 80 to put it into the units of dynes per second per centimeter minus fifth. There's the normal value for systemic vascular resistance. Again, you won't need to memorize that. I'll have that for you on the test. And then we can index that value also by dividing by cardiac index as opposed to cardiac output. Pulmonary side, same thing. High point minus low point divided by the cardiac output times 80. You can see this pulmonary vascular resistance is but a mere fraction of the systemic vascular resistance. It's a very low pressure system, and you can index that value also. Afterload, how do I get the afterload higher? Well, I use drugs that cause arteriolar vasoconstriction, various vasopressors that act on the alpha receptors within the arterioles to cause vasoconstriction and improve blood pressure. Normally, we want to verify that we're not just fluid depleted first, so we would never start somebody on a vasopressor until we've optimized their vascular volume. So if somebody's bleeding out and they have a very low blood pressure, I'm not going to put them on a drug that increases their vascular tone until I've replenished the volume. Multiple vasopressors you encounter. Epinephrine typically is not utilized as a first-line mechanism, but it is a drug which has both alpha, beta 1, beta 2, so it's kind of hitting everything. It is our primary drug we'll find that we're using in any pulseless patient during cardiac arrest. All dead people get epi. It's a general rule. Levophed or norepinephrine is one that is used in the ICU more commonly. Vasopressin is one that is used as a substitute for epinephrine during ACLS. And in the OR they use one called neosynephrine, phenylephrine is another one that anesthesia we use a lot. But typically what we end up seeing are other drugs that I'll cover when we get to there, things like dopamine and dobutamine that are more commonly used to regulate blood pressure. Does that seem what you guys are seeing? Is that a pretty... Levophed? Or what we politely call leave 'em dead? If the afterload is too high, we can do use various drugs to reduce afterload. Especially on a chronic basis, diuretics are used in combination with either ACE inhibitors or angiotensin II receptor blockers. But there's multiple ways to be able to regulate blood pressure in the process. The beta blockers, remember, end in that OL, atenolol, metoprolol, propanolol. That's one way. Not only does it decrease heart rate and force a contraction, but in the process you end up lowering blood pressure. And ACE inhibitors block the conversion of angiotensin angiotensin 1 to angiotensin 2, and that occurs in the lung. And you'll notice they all have kind of IL at the end, so a whole slew of them. Calcium channel blockers inhibit the movement of calcium back into the cell, therefore reducing constriction of the vessels. And they also have some effect on heart rate, as we'll end up seeing in some of these tachydysrhythmias. ACE2 block the effect of angiotensin II on the receptor sites of the arterioles, and these are often used as long-term management of blood pressures. And in vasodilators in the ICU, that second one would be one we would probably see, sodium nitropresside or niopride, along with nitroglycerin, are very, very potent vasodilators. Somebody who comes in with a blood pressure of 220 over 160, you want to get that pressure down as quick as possible. These drugs will do it for you, any of your nitrates. And then finally, the third component of stroke volume is contractility. And this is basically, given a preload, how much oomph does that muscle have? You can think of it as the thickness of the rubber band. Higher contractility will yield a higher stroke volume for a given preload and afterload. And this is kind of just thinking of it as same as lung compliance. Same idea here. It's the compliance of the left ventricle. Higher for a given preload, as I move up and have improved contractility, I have a higher stroke volume for a given preload. Contractility can be increased through things like cardioglycosides, your digoxin, it's been around forever, and then your sympathmimetic drugs, the ones we typically see used, dopamine and dobutamine, will improve cardiac output. And we'll leave it at that. Reducing contractility, it seems kind of counterintuitive. Why would I want to reduce contractility? Well, there's actually been shown in patients in acute MI, giving them a beta blocker, reducing the contractility will actually improve long-term wise, the healing of the myocardium and outcome has actually been shown to be beneficial, giving a beta blocker early on in an MI by reducing the amount of oxygen demand.
You get snipers, beta blockers. It decreases their shaking.
Okay.
Their heart rate, so like, you know, if they're aimed up.
Okay.
Piece of information for everybody. Fun fact of the day. Yeah. They give Inderall, actually.
We don't have snipers often. Hopefully not in the classroom. But. So again, if I have a decreased stroke volume, you have to go through the process of elimination as far as whether it's preload, afterload, or contractility. And part of the goal is that you should have an idea of what measurements would need to would allow us to be able to determine which of these is the problem. If I have a high stroke volume, there's something I would need to do to accommodate, if that's what the goal is. We know that we can monitor blood pressure continuously by placing an arterial lines. From last semester we talked about different cannulation points. Typically it's the radial artery, could be the femoral artery, the umbilical artery in the newborn, remembering that is postductal blood. And then there's various complications of monitoring in that process. We know normal blood pressure 120/80. Hypertension is anything over a systolic of 140 or a diastolic of 90. Hypotension is anything under 90 or 60. More often we'll use the mean blood pressure to be able to quantify that. This is just obviously too low or too high. Both will cause problems. Been through that. You know how to calculate mean blood pressure. Pulse pressure is the difference between the two, the systolic and the diastolic. And usually a reduction in pulse pressure is indicative of a reduction in stroke volume. And that's basically one of our first signs we're telling us that we have inadequate blood volume, so a reduction in preload, reducing that. Pulsus paradoxus is the change by more than 10 millimeters of mercury on inspiration between the systolic during inspiration versus the systolic during expiration. You can also use it by assessing just simply by the pulse strength being changed. And usually it's a sign of some kind of increased pressure within the chest as far as what you would see in status asthmaticus or cardiac tamponade. Alternative to calculating mean arterial pressure, it also is derived by the cardiac output times the systemic vascular resistance, and breaking the cardiac output out into its two components, the stroke volume and heart rate. You can calculate it that way also. We know that arterial line is basically a transducer, the strain gauge transducer. As the pressure in the vascular system changes, it changes the resistance, or changes the pressure placed upon that strain gauge, which then will change resistance of the electrical current flowing through it. I think I talked about the fact that the transducer always has to be calibrated at the level of the heart. And if I change the level of the bed, I'll actually change the displayed blood pressure, so that as I make the transducer higher than the patient, I'll actually lower the blood pressure. It's an inverse relationship. So here it's being referenced to the patient's heart. And it's just showing the solution. We've been through all this before. So kind of a review. Same system can be used to hook up to the distal port or the proximal port of a PA catheter to be able to measure the CVP and the PA pressures. This is just talking about sampling. and how the catheter system should be monitored. There's my dicrotic notch. Damping we've talked about before, over and under damping. Properly damped where I end up seeing a nice dicrotic notch. Over damped, meaning it's not a responsive, not a quick rise to pressure. Some of the causes that we've been through. Under damped is an over responsive system where I'm getting a lot of artifact. Some of the causes of those. And I think that's where I'll stop.